Good evening, everyone. So this week we'll be continuing our lecture on dermatopathology. If we look at the first video of the series, which was about 2 weeks back, we discussed the histology of the epidermis, in which we discussed the separate layers and the individual cells that were forming the different layers of the epidermis. We started from the basal cell and gradually migrated to the corneocyte. We also discussed the various epidermal reaction patterns, at least the normal one that we usually see in the biopsy slides. And this week we'll focus more on the dermal pathology or dermal histology. It is very important to understand the normal dermis first. We need to understand the architecture, the fibers, the cells, and the structures that form the normal dermis so that we know what we are looking at when we look in the microscope. If we know what is the normal architecture of the structures or the architecture of the dermis, we'll be easily able to find different pathologies during while we are analyzing slides of skin biopsies. Okay, and so understand that to make sure that we have a good fundamental grasp of the foundations of dermal pathologies, we should look at the normal histology of the dermis. And what we're going to do in this lecture is I've divided this lecture into three parts. We will first look at the fibers forming the dermis, then we'll look at the individual cells that we see in the dermis, and then third, we'll look at the different structures that form the dermis. And this would be a rather long lecture. So without much further ado, we're going to start the histology of the dermis. So dermis comes from mesenchymal origin. It's totally different from the origin of the epidermis. The epidermis is formed from different part. Dermis forms from different part. So dermis comes from the mesenchyma. It is a part. It is a form of connective tissue, and it has a fibrous structures. We do know that the major fibers of the dermis is the collagen fibers, which makes about 70% of the dermis. So dermis in itself is a fibrous structure. The fibers, apart from collagen, include elastin fibers and the ground substance. The ground substance has hyaluronic acid, glycosaminoglycans, glycoproteins, and proteoglycans in various orders, but the majority of the dermis is made up by the collagen. Okay, coming to the cells of the dermis, we have the fibroblast. Fibroblasts are the major or the predominant cell types that we see in the dermis. Along with that, we have mast cells, histiocytes, adipocytes, and there are different cell types which come into the dermis in inflammation. For example, we have lymphocytes, we have neutrophils, eosinophils that we see in various pathological disorders. So we will be discussing individual cells gradually as we proceed through the lecture. The other things are the components or the structures that we see inside the dermis, which includes vessels. Now, vessels can be capillaries, arteries, and venules, arterioles and venules. We can also see the nerve endings, hair follicles, and the various glands, which include sebaceous glands, eccrine sweat glands, and apocrine sweat glands that we see in the dermis. So individually, or we can study the normal histology of dermis by dividing into three parts: fibers, cells, and the individual structural components. Now, as we analyze a biopsy, we can easily identify the basophilic epidermis. So this is basophilic. That means it's more bluer, it's purpler. It's more purplish than the dermis, and that basophilic is actually the epidermal part. The lower or the major chunk of the biopsy is made by an eosinophilic dermis. So it's more pinkish, it's lightly stained, it's pale, okay? Now the dermis is divided into two parts, and this division is not exact, it's a bit arbitrary. So we have this retipegs, okay? Just look at this diagram. The part of the epidermis that goes inside the dermis are known as retipegs. Okay, and the part of the dermis that goes inside the epidermis are known as the papillary dermis. Okay, this part is papillary dermis. So there is a somewhat of a division, an arbitrary division between the two parts. The upper part, which is abutting the retipex, is known as papillary dermis. Okay, it is known as papillary dermis. This part, which is within the retipex. Okay, the retipex go down, the dermal papilla go up. The dermal papillary part is known as the papillary dermis, while the rest of the dermis is known as reticular dermis. So this division is somewhat arbitrary, although some pathologists consider that there are two different types of vascular plexus. One is the superficial vascular plexus and one is the deep vascular plexus. Okay, plexus. Okay, and the presence of superficial vascular plexus is where above the plexus we say papillary dermis and below the plexus we say reticular dermis. But this distinction is not that separate, not that clear cut. Okay. There are subtle differences between the papillary dermis and the reticular dermis. The papillary dermis is arranged along the retipex. It's looser, it's more vascular because there are a lot of capillaries inside there. It has vertically oriented elastic fibers. That means the elastic fibers are oriented in this manner. It has thinner collagen and elastin and is predominantly composed of type 3 collagen. While in reticular dermis, it is from retipex towards the subcutis, that means till the bottom end of dermis. It is more compact and dense. It's less vascular as compared to papillary dermis. It has horizontally arranged elastin fibers, so like in this, thicker collagen and elastin, and the collagen is predominantly type 1. Okay, in papillary dermis it's type 3. Mention in the comments where we see type 4 and type 7 collagen in the dermis. Okay, so this is the essential differences between papillary dermis and reticular dermis. Let's move forward. So this is a skin biopsy slide of H&E stained normal skin, and in this we can easily see that this part from here to here is papillary dermis. Okay, papillary dermis, while from this towards the end will be the reticular dermis. And you can easily see that the papillary dermis is more compactly arranged. You can see that the collagen fibers are thinner, but they are more densely arranged, while the reticular one is more a bit separate with thicker collagen bundles. Can you see that from here onward, this is a thick collagen bundle and this is a thick collagen bundle, while in papillary dermis, it is more of a thinner collagen bundle. So this is how you distinguish between papillary dermis and reticular dermis. Okay, let's move forward. So we start the first part of the lecture. We'll discuss the fibers of the dermis. So we have discussed papillary and reticular dermis. Now we'll understand what is this difference between the collagen fibers of individual areas. Let's start first with collagen. So collagen, both type 1 and type 3 are the major component of the dermis, making up to about 70% of the dermis is made up by the collagen fibers. They are responsible for structural integrity and the form of the dermis and also provides tensile strength to the dermis. So collagen essentially gives the dermis strength. Okay, it's eosinophilic, that means it is pinkish to red stained, pink stained, wavy. You can see it looks a bit like a wave, a wavy, and fusiform. So fusiform is one thing which is tapering. So in the previous diagram or the previous slide picture that I showed, the last slide, you can see that this is more of a slender eel-shaped or a worm-shaped fibers which are eosinophilic, wavy. So these are the collagen fibers which predominantly make the structure of the dermis. When you're looking at a slide of a dermis, the major part that you are going to see in H&E stain slides is the collagen fibers, the eosinophilic collagen fibers. So let's look at this slide. You can see this. Let me just change the color of the pen. So these are thicker collagen bundles. So these are all collagen bundles. Can you see? Can you appreciate? Here you can see a wavy collagen bundle. This is a wavy collagen bundle. So you can see the pale stained, pink stained, okay, a thicker bundle, uniformly stained. So it looks a bit like this, isn't it? Fusiform, wavy, eosinophilic structures. Predominantly, the entire dermis is composed of just collagen fibers because they are the most predominant fibers that you see in the dermis. Now let's discuss the second type of fibers, which are the elastic fibers. And these elastic fibers are of two types, elastin and fibrillin microfibrils. So what do we see? We actually are not able to appreciate or see elastic fibers on routine H&E staining. Okay, on routine H&E stain, the elastic fibers are not that easily visible. You can easily miss, they are not appreciable. But they are thinner, they are longer, and they are responsible for gliding, stretching, and recoiling of the dermis. Basically, they give the dermis elastic tensility or elastic strength. And because of this elasticity, the dermis is not stretchable. Okay, so collagen gives strength and elastic gives stretchability or flexibility. There are two types majorly of elastic fibers. You have Elastin fibers, which are horizontally arranged like this, and they are found more in the reticular dermis, while the oxytocin fibers are perpendicularly arranged and they're mostly seen in papillary dermis. So there is another difference between papillary and reticular dermis, that you have Elastin fibers in reticular dermis and oxytocin fibers in papillary dermis. Okay, let's move forward. So this is a von Giesen stain slide. As I said that on routine H&E staining, you cannot appreciate much about the elastic fibers. But on special staining like von Giesen stain, the elastic fibers are stained darkly. They are stained black or very dark blue. And all these black structures that you can see here are actually elastic fibers. Okay. And because of this elastin, it is predominantly placed in between the collagen bundles, and that is how it gives the gliding motion or the gliding ability to the dermis. Okay, so now we are utilizing a special stain to see elastin, and that is the von Giesen stain. So this is a slide which shows the elastic fiber, the vertically oriented elastic fibers. So you can see this vertically oriented elastic fibers to make it more appreciable. Now this is H&E stained. Okay, this part is H&E stained. So you cannot appreciate the elastic fibers here, but when you use special staining techniques, you can easily see the vertically oriented elastic fibers which are darkly stained. They are thinner, they are more fibrillar or hair-like as compared to collagen bundles. Okay, so these are elastic fibers. Let's move forward. So we have learned about the two major fibers in the dermis, collagen and the elastic fibers. Now we come to the second part of the lecture, which is the cells of the dermis, all the cells that we see. And we will start our lecture with the first and the most predominant cell of the dermis, the fibroblast. Now, fibroblasts are the principal cells of the dermis. Okay, principal cells of the dermis. They are disc-shaped, elongated cells. So, more of they are like flattened cells, like this. Okay, they are disc-shaped, elongated cells with long, thin, pale staining processes. So, these are the processes, or dendritic-like morphology, or different thin arms, like this. Okay, somewhat like this structure. The nuclei is oval or spindle-shaped with moderate basal staining. Basal means basophilic staining. So it is more darkly or blue stained, while the entire cytoplasm is pinkish pale stained. Fibroblasts are responsible for secreting collagen, elastic fibers, reticulin fibers, and the extracellular matrix, or the ground substance, is majorly constructed or secreted by fibroblasts. Now, these fibroblasts are very difficult to identify on H&E, but if you look closely in between the collagen bundles, you will easily see pale staining flattened cells, which are the fibroblasts. Now, these fibroblasts are increased in disorders like morphea or scleromyxedema. So in the biopsy from these disorders, you can easily appreciate fibroblast. Okay, so let's move forward and see them. The second cell that we'll discuss now are the lymphocytes. Now, lymphocytes are not traditionally present in the dermis. They are present inside the vessels. They are part of the blood. Okay, but whenever there's going to be an inflammation, you will see perivascular lymphocytic infiltrate. So predominantly, you will have lymphocytes as the major cells inside the inflammatory infiltrate. The cells are 7 to 12 micrometer in diameter, and they are small, round, deeply basophilic nuclei surrounded by a thin rim of cytoplasm. So in this figure, you can easily see the thin rim, the thin surrounding rim of cytoplasm, while the nucleus is intensely basophilic. Okay, lymphocytes constitute the chronic inflammatory infiltrate. Now remember, whenever there's inflammation, during the early stages of inflammation, the first cell to arrive is neutrophils. Okay, neutrophil will come first and start the inflammatory process. As the process is prolonged, the cells are gradually replaced by a predominantly cellular infiltrate composed of lymphocytes. So whenever you're going to see a biopsy, which is from a chronically inflamed skin, you will see majorly the lymphocytes. Now, there are multiple disorders which have lymphocytic infiltrates. You can have lymphocytic infiltrate in the upper dermis, known as interface dermatitis, isn't it? So, in those it is very essential. It is important for us to recognize lymphocytes whenever we are analyzing an inflammatory infiltrate. Okay, so let's move forward. The third most important cell are histiocytes. So whenever you read a biopsy a pathologist's description of skin biopsy, it always mentions lymphohistiocytic infiltrate. What do we mean by that? It means that the infiltrate is composed of predominantly lymphocytes and then we have histiocytes. Okay, most commonly the nature of infiltrate would be such that it has both lymphocytes and histiocytes mixed together, and if histiocytes are more than lymphocytes, you have histiolymphocytic infiltrate. Or if you have lymphocytes more than histiocytes, then you have lymphohistiocytic infiltrate. Okay. Now let's learn about the third cell, histiocytes. They are larger than lymphocytes, with size ranging from 15 to 25 micrometers. On a routine H&E staining, it is difficult to see those cells. Okay. In H&E staining, it is difficult to make out where the histiocytes are or where the lymphocytes are. What histiocytes are essentially are they are tissue macrophages. Now, macrophages are a part of blood. They will stay inside the vessels. But some proportion of those macrophages will come out of the blood vessels and during inflammation will stay inside the skin. And these resident macrophages are known as histiocytes. They are fairly large. We have told you that they are larger than lymphocytes. They are fairly large, lightly staining. That means they will be pale as compared to lymphocytes. Sometimes vesicular, that means you will see vesicles inside the cytoplasm, making it a bit more, you could say, ground glass opacity or somewhat of a haziness inside the cytoplasm. The nucleus would be elongated while the lymphocyte has a round nucleus. The cytoplasm is pale and margins may be indistinct. That means if you have another histiocyte lying around, you might not be able to appreciate the distinct cell membrane in between. You might see it just as a group of two nuclei hanging together. Okay, they have different shapes. They can be dendritic, spindle shaped, or epithelioid, predominantly when they form granulomas, which are an important aspect of granulomatous inflammation. They are the inductors of cellular inflammation and responsible for wound healing and homeostasis. So that is as they are a group of macrophages essentially, they are frequently seen in healing process, in the chronic inflammations, and also to maintain the normal upbringing of the dermis. Now, as I've said previously, that predominantly most of the infiltrate is composed of lymphocytes and histiocytes. Now, if you look at this picture very carefully, you will see that the infiltrate is largely blue colored, it's darker colored. That is why we say that the infiltrate is majorly composed of lymphocytes more than histiocytes. That makes the infiltrate lymphohistiocytic. Okay. If you look at the shorter arrow, here is a cell which is a lymphocyte. You can easily appreciate lymphocytes. They are circular, and the blue color that you are seeing is not the cytoplasm. It's the nucleus which is so large that it is occupying the whole cell. So all the blue colored areas, all the cells that you can see here are essentially lymphocytes. Now, if you look at the larger arrow, it is actually pointing towards a histiocyte. So let me just erase the boundary and you can appreciate this. The histiocyte is larger than lymphocyte, roughly twice the size. And you can see that the cytoplasm has little vesicles, white dots, making it more, somewhat like a foamy appearance. These are not foamy histiocytes. Do not confuse them with foamy histiocytes. These are normal histiocytes that you see. In fact, you can see one histiocyte here. You can see one histiocyte here. You can see one histiocyte here. So this is filled with histiocytes, different types of histiocytes. And most of the time, you will see both of these cells together in any infiltrate. Okay. Let's zoom it up a bit. So if we magnify, we can easily make out the lymphocyte here, the lymphocyte here, the lymphocyte here, lymphocyte here. And if we look at the histiocyte, this is a histiocyte. As we have described before, that the cell membrane of histiocyte is not that clear. So you are not able to make out where one histiocyte ends and the other begins. Here you have a histiocyte, here you have a histiocyte, here is another histiocyte. So pause the video and spend some time analyzing the previous slide and this slide and look at wherever you can isolate histiocytes in this infiltrate so that you can easily find. Now, many of the time it is said that the histiocytes have a slipper nuclei or a slipper shape. That is essentially saying that it looks like a slipper, okay, like a footwear. But predominantly, they can be of any shape. They can be elongated. Then they are called as slipper-shaped nucleus of histiocyte, and that makes it easier to identify. For example, here you can see a slipper-shaped nucleus. Here you can see a slipper-shaped nucleus. Now that is how you identify and differentiate between histiocytes and lymphocytes. Lymphocytes are more basophilic, while histiocytes are eosinophilic. And here, you just look at these two diagrams. Okay, look at these two diagrams, and you can easily differentiate between a lymphocyte and a histiocyte. So whenever you're looking at a slide, it is very important to categorize as lymphocytic infiltrate or histiocytic infiltrate and which cell population is more than the other. Okay. So while it becomes very important while analyzing slides from leprosy patients in which you have to describe whether it's predominantly lymphocytic going towards the tuberculate pole or it is more histiocytic going towards the lepromatous pole. Okay. So if just practice looking at slides and try to isolate individual histiocytes and lymphocytes. Now coming to the fourth cell type, the plasma cells. Now plasma cells are predominantly a part of the humoral immunity system. That means they are responsible for making antibodies. Okay. Now, plasma cells get migrated when you have antibody secretion, or they can migrate as a part of general inflammation. See, whenever there's inflammation, the vessels are going to leak the cells inside the dermis. That is what inflammation is, leaking of cellular contents. And when all the cells are getting leaked out of the vessels, some cells like eosinophils, plasma cells will also form a part of that infiltrate. Okay. Now, plasma cells have abundant basophilic cytoplasm. That means the cytoplasm will stain blue. Okay, so it has abundant basophilic cytoplasm. Compare that with eosinophil, which has more eosinophilic cytoplasm, or histiocyte that has a pale staining cytoplasm. It has a round eccentric nuclei. Eccentric nuclei means the nucleus is not at the center, it's to the side. So you can see the diagram, it's shifted towards the side. The size is about 10 micrometer in diameter, roughly in between histiocyte and lymphocyte. It has a clock phase arrangement of chromatin. Now, what do we mean by clock phase? So let us imagine a clock. So here it is 12, 6, 3, and 9. So in any clock, you will see markings here like this, isn't it? You see markings here to indicate the different numbers on the clock. Now in the nucleus of plasma cell, the chromatin is arranged at the periphery like this. And this is what is known as the clock phase arrangement in plasma cell. And when this chromatin is arranged a lot, it gives the shape of a cart wheel, okay, like the wheel of a cart. And that is why it is known as cart wheel nucleus. So if you look at this diagram, look at this nucleus. This blue staining thing is actually chromatin, while the purplish is nucleoplasm. Wrong spelling. The purplish is nucleoplasm. Nucleoplasm, okay. And because the chromatin is at the periphery, the nucleoplasm looks like the spokes of the wheel, and that is known as cart wheel nucleus. There is a zone of pallor adjacent to the nucleus known as the perinuclear huff, which is the Golgi apparatus. So here you will see a pallor area, that is the Golgi apparatus. You can have eosinophilic globules in the plasma cells, and those are known as Russell bodies. Now, I will not go into detail about the structure of plasma cell. Maybe when we are discussing plasmacytoma in some future video, we'll discuss Russell bodies. They are predominantly responsible for immunoglobulin production, And whenever you see a plasma cell which infiltrate, you think of disorders like syphilis, like zooms. Okay, so you think about this disorder when the infiltrate has a lot of plasma cells. Let's move forward. So look at this arrow. Can you make out this cell? This cell, yes. So you can see that the nucleus is towards one side. So it kind of mimics the diagram that I've made here. Okay. It it is towards the one side, and you can appreciate the dots inside the nucleus. And that makes it look like a cartwheel or the clock face arrangement of the nucleus. So here also you can see another plasma cell. Okay, just pause the video and look at this slide and try to find out where you can find different kind of plasma cells. Here is a plasma cell, here is a plasma cell, here is a plasma cell. So this is a plasma cell rich infiltrate. Okay, let's move forward. Now, the fifth cell type that we'll discuss are the eosinophils. The eosinophils are large cells, about 10 to 17 micrometer across. Okay, the nucleus is bilobed. So there are two lobes. So you can see the two lobes here. The nucleus is bilobed. The cytoplasm has a lot of eosinophilic granules, and that makes the cytoplasm of eosinophils eosinophilic. That means red staining. Red staining. And because of this red staining or eosinophilic cytoplasm, the cells are known as eosinophils. Okay, so if you see a eosinophilic cytoplasm cells with bilobed nucleus with two lobes in the nucleus, those are eosinophils. The eosinophilic granules are a lot more as compared to the eosinophilic granules that you see in neutrophils. So see, neutrophils are supposed to release chemicals that will destroy the inflammatory pathogen. Okay, these granules are stored inside vesicles, which are eosinophilic, basophilic, a lot of different granules. But these granules, when they are released outside the cells, they will destroy the inflammatory pathogen. Eosinophils also have similar granules, but the contents of those granules are red staining eosinophilic contents, and that gives the red color to the cytoplasm. And that is how you identify eosinophils in a dermal slide. These granules contain hydrolytic and proteolytic enzymes which will destroy the pathogen when they are released outside. And we remember that eosinophils are responsible to destroy, extracellular parasites. Parasites which are large enough so that one cell cannot engulf it. So eosinophil release these enzymes, release these proteolytic and hydrolytic enzymes and destroy the pathogen. They are seen in infections, insect bites, and foreign body reactions. So look at this slide that I've taken from Rooks. You can easily see a cell which has a red cytoplasm. You can easily appreciate the red cytoplasm, and you can easily see the two lobes. So here also you can see two lobes with red cytoplasm. Okay. In other areas the two lobes are not that appreciable, but this is also an eosinophil, and you can actually make out those red dots which are the eosinophilic granules in the cytoplasm. So look at this. There is also one eosinophil here. It's filled with eosinophils. Okay, and eosinophils are a major cell type which you see in the dermal reaction pattern or dermal uh, insect bite hypersensitivity reaction or a dermal hypersensitivity reaction pattern. The eosinophils make up the major chunk of cellular infiltrate. Okay, let's move forward. Now the sixth type of cell that we'll discuss are the neutrophils. The neutrophils are the most numerous of WBCs, constituting about 50 to 70%. And that you can see in any of the DLC blood reports that you see in the patient, that 50 to 70% of WBCs are neutrophils. They have multi-lobed nucleus. So here in the diagram also you can see that there are multiple lobes, roughly 3 to 4 lobes. You can go as high as 6 lobes of the nucleus, and it has basophilic cytoplasm. So basophilic means more blue or purple staining. In eosinophils, it was eosinophilic cytoplasm, which is red staining. In neutrophils, it is blue staining basophilic cytoplasm with smallish granules. The granules are smaller as compared to eosinophils. Neutrophils are responsible for phagocytosis. That means they will engulf and eat the bacteria or the pathogen. They are the first responder to injury. As I've said, they're the first cell to come at the site are the neutrophils. They're majorly seen in infections, inflammatory disorders, and vasculitis. But we'll discuss them when we're discussing reaction patterns in the next video. So in this picture, you can easily appreciate one neutrophil lying here, okay, and another neutrophil lying here. You can look closely and see that the nucleus has a lot of lobes. Okay, if I try to make a diagram, this is looking like this, isn't it? This one, let me just stain. So now it looks like the diagram. Okay, now you can appreciate neutrophils. These neutrophils are not part of the infiltrate. They are inside not inside. They are part of the just bleeding that has occurred during the biopsy. But you can easily appreciate the structure of the neutrophil. So this is the complete photo of the slide, and this is not a vessel membrane. This is not the vessel wall. This is actually stratum basale. So if any of you know what this slide shows, what is the pathology being shown here, mention that in the comments with the time stamp, and let me know if you can easily diagnose this very common skin disorder. Now, the seventh type are the mast cells. The mast cells are also larger, 9 to 16 micrometer, and they are undifferentiated mesenchymal cells. Normally, they are found around the blood vessels because they are part of the roaming blood cells, but the concentration or the population is low. The nucleus is central. Okay, the nucleus is central. That means it's at the center of the cell. Okay, it is round to ovoid. So you can see the ovoid nucleus here, and it is dark staining. So it stains darker than the surrounding cytoplasm. These cytoplasms are small granules that stain metachromatically. And then we are talking about the small granules inside the cytoplasm. They stain metachromatically. Now, what do we mean by metachromatic staining? Metachromatic staining means that the stain has different color and the organelle or the part of the cell that the stain is usually used to put color is a different color. Okay. For example, if I have a stain in a bottle and the color is, let's say, blue, and I use it to stain a structure, let's say a large cell, the cell actually gets stained green. So this color is different than this color, and this is known as metachromatic staining. Okay. So the mast cell cytoplasm has small granules that stain different from the color of the stain that is used, and the stain that we use specific for mast cell is toluidine blue. And we learn more about toluidine blue when we are studying mastocytosis or mastocytomas. But there are different stains, and what all special stains are used to stain mast cells is a very important viva question. So toluidine blue is one of them, the most important stain for mast cell. Mast cells are seen in mastocytosis, benign and malignant nerve tumors, and also in melanocytic nevi. So look at this cell. Look at this cell here. It is red staining cytoplasm, and an oval dark staining nucleus. And this is a mast cell. Okay. And in many of the areas, like in previous slide I forgot to highlight, it is known as a fried egg appearance. So it looks like a fried egg when you see from the top. So doesn't it look like a fried egg like this? Look at this cell. Look at this cell. It looks like a fried egg. In fact, this here also is a mast cell. It is just flattened. Look at a fried egg mast cell here. Look at a fried egg mast cell here. Those of you who cook or make eggs, can easily identify a fried egg appearance of mast cell. And here is a little small eosinophil. Okay, so we will slowly you'll be easily able to pick up different cell population in infiltrates, and that will make your reading of a biopsy slide very much accurate and better. So with that, we've finished the second part of this lecture. And at this point, I'll take a very short break and we will continue with the third part of the lecture known as structures of the dermis, in which we'll see different structures like the hair follicle, nerves, and blood vessels. And we'll take a short break, drink some water, go to the loo, and come back. And we'll continue with the third part of the lecture, structures of the dermis.